Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting and exciting topic, the pediatric epilepsy. Pediatric epilepsy in nutshell. So I'll be dwelling on all the important concepts of pediatric epilepsy, the pediatric epilepsy in nutshell. Seizures, the classification of seizures. The seizures can be classified into two main broad categories, focal seizures and generalized seizures. As the name focal implies, it starts from a particular region of the brain, a focal region of the brain. Whereas if it is generalized seizures, from thalamobilateral bicortical spread occurs, and to start with, it's a generalized seizure. So focal seizures can be again classified into three broad categories. The three broad subcategories: simple focal seizures, complex focal seizures, and complex focal seizures with secondary generalization. In simple focal seizures, there is no impairment of consciousness. Very important point. The simple focal seizures, there is no impairment of consciousness. Persons are well awake and oriented. There can be motor manifestations like tonic-clonic, or a sensory manifestation, or sometimes an autonomic manifestation if the temporal lobe gets affected. It may or may not evolve into a complex focal seizures. But the bottom line is that in simple focal seizures, the consciousness is intact. There is no impairment of consciousness. Whereas in complex focal seizures, there is focal seizures with impairment of consciousness. They get disoriented. So there is an impairment of consciousness. And if the complex focal seizures then may spread to bicortices and can become secondarily generalized. So this is about the focal seizures. When we come to the concept of generalized seizures, there are basically absence seizures, which is otherwise known as petit mal. We have myoclonic seizures, clonic seizures, tonic seizures, tonic-clonic seizures, what we call as grand mal, and sometimes atonic seizures. So these are the broad categories of the generalized seizures. Each seizure type we will see in the subsequent discussion, right? But what is very important amongst the pediatric epilepsy group is that febrile seizures, they are very common in the pediatric age group, occurring in 2 to 5% of the children. It is the most common type of seizure disorder. Febrile seizure is the most common type of seizure disorder. It is seen in the ages between the 6 months period to 5 years. So it is common between 6 months to 5 years. So if we see seizures in children between 6 months to 5 years of age, we should always suspect febrile seizures. And febrile seizures are usually not associated with CNS abnormalities or CNS infections. They primarily occur during fever, especially at the peak of the fever. So seizures associated with high temperature, especially occurring at the peak of fever, without any neurological involvement or neurological lesions like infections, we call that as febrile seizures, and is very common in pediatric age group. It is about 2 to 5% of childhood, and usually seen between 6 months to 5 years of age. But then here again a very important concept is present. One, the febrile seizures again can be broadly categorized into simple febrile seizures and complex febrile seizures. Why is this important? The simple febrile seizures usually do not progress to develop epilepsy, whereas complex febrile seizures may sometimes progress to develop epilepsy at a later point of time, and then we need to give anti-epileptic drugs on a continuous basis. In complex febrile seizures, if they develop into a epilepsy. Whereas simple febrile seizures are simple and usually they are remittent in nature, they usually do not progress at least to the point of developing epilepsy. So how do we differentiate simple febrile seizures and complex febrile seizures? Simple febrile seizures are brief and usually generalized. They are generalized. Whereas complex febrile seizures may be focal. Particular part of the brain may get affected. And usually simple febrile seizures last less than 15 minutes, whereas complex febrile seizures last more than 15 minutes. And the simple febrile seizures, they do not recur within 24 hours, whereas complex febrile seizures usually recurs within 24 hours. And as I said, simple febrile seizures usually do not progress to epilepsy. The chance of getting epilepsy in simple febrile seizures is very, very less, to the tune of 1 to 2%, almost as common as in the general population. Whereas persons with complex febrile seizures developing to epilepsy is more common, about 5 to 10%. And therefore, for simple febrile seizures, we do not give anti-epileptic drugs on a long-term basis. We generally treat the cause of the fever and give seizure or drugs only during that period of seizures, that period of febrile seizures where they are throwing seizures. Like clobazam. Clobazam is a wonderful drug because it can be given as an intermittent therapy, unlike other anti-epileptic drugs like phenytoin, phenobarbital, carbamazepine or sodium valproate or levetiracetam, where we give it on a chronic basis. If we think that the seizures occur only during a particular period and then it stops, then the wonderful drug, anti-epileptic drug to be given is clobazam, because clobazam can be given as an intermittent therapy, like febrile seizures where they get seizures only during fever, especially at the peak of fever, or in women, catamenial epilepsy, where they develop seizures during periods, or some children or some people who get seizures or epilepsy when they take hot water. So only during those periods of time we give clobazam as intermittent therapy, otherwise we need not give. So for simple febrile seizures, we can give clobazam as an intermittent therapy when they throw seizures and the symptomatic treatment of fever. Whereas complex febrile seizures, they may go on to develop epilepsy. In case there is a chance of going on to develop epilepsy, then we have to start an anti-epileptic drug. A very good anti-epileptic drug of childhood is phenobarbital. Right. So febrile seizures is very important because a very common cause of seizures in pediatric age group. The next is the neonatal seizures. As the name implies, the seizures occur in less than 1 month. So seizures occurring in less than 1 month of age of babies is known as neonatal seizures. The common causes are hypoxic ischemic encephalopathy, when there is insufficient oxygenation to the brain, or hemorrhage like intraventricular hemorrhage or subarachnoid hemorrhage or subdural hemorrhage, or cerebrovascular insufficiency, ischemic strokes, CNS infections, especially viral infection, HSV, encephalitis, because it affects the temporal lobe and can cause seizures, herpes simplex encephalitis, metabolic like hypoglycemia, electrolyte disturbances like hyponatremia or hypernatremia, or genetic or inborn errors of metabolism. The treatment is phenobarbital, as with usually with childhood epilepsy, with other forms of seizures in childhood. The treatment is phenobarbital. Sometimes we see seizures only on the 5th day, what we call as 5th day seizures. They are benign familial neonatal seizures. Next type of seizures, what we see in a slightly older age group, lesser than 1 month, we call it as neonatal seizures. If we see slightly in older age group, that is 4 to 7 months, it is usually infantile spasms. Infantile spasms, again, usually they are because of hypoxic ischemic encephalopathy. Infantile spasm, as the name implies, infantile, less than 1 year, spasms, that is contractures. Usually they'll have flexion of the trunk, neck, extremities, as if they are coming and hugging themselves. So infantile spasms, they are very painful, and sometimes the children cry also with pain. They occur in clusters. The EEG is very characteristic of infantile spasms. It is known as Hips arrhythmia. Hips arrhythmia is actually a triad. They have a high amplitude, then they have a disorganized background, and they have the multifocal discharges. So EEG is very characteristic of infantile spasms, what we call it as hips arrhythmia. It's a triad, high amplitudes, disorganized background and multifocal discharges. The treatment is adenocorticotropic hormone ACTH, or if persons have tuberous sclerosis presenting as infantile spasm, the anti-epileptic drug of choice is vigabatrin. But we need to be careful with vigabatrin because it can cause visual disturbances and field defects. So infantile spasms, one of the common causes hypoxic ischemic encephalopathy. So next 4 to 7 months is infantile spasm. At slightly still older age, we see is West syndrome. West syndrome is actually a triad. It's sometimes a progressive form of infantile spasm. So the triad consists of infantile spasms. So West syndrome consists of infantile spasms, hips arrhythmia of the EEG, and a developmental regression. And therefore, we do not treat infantile spasms adequately and effectively. It may go on to develop as West syndrome with developmental regression. And a still later form, they may go on to develop Lennox-Gastaut syndrome, that is in the children. Lennox-Gastaut syndrome, they have multiple seizure types. They have almost all types of seizures, atonic, tonic, clonic. So multiple seizures type they have. And the EEG shows a slow. Slow indicates that the brain is really affected severely, and it is diffuse. That means it is a generalized form of involvement, very slow, because the brain is severely affected. The frequency is very slow, about 1.5 to 2.5 hertz, and the treatment is very difficult to treat Lennox-Gastaut syndrome. So sometimes we give ketogenic diet so as to make the brain utilize ketones rather than the carbohydrates. So it may be one form of treatment for Lennox-Gastaut treatment, ketogenic diet. We can, since it spreads to both the cortices and it's a generalized disorder, we can do corpus callosotomy so that the spread of seizures from one cortex to other cortex may be prevented. And third, we can do a vagal nerve stimulation. So actually this could be a continuum on a continuum spectrum: infantile spasm, West syndrome, and Lennox-Gastaut syndrome. The next common seizures what we see in childhood is childhood absence epilepsy. It is seen between the 4 to 10 years, still slightly older group. So 4 to 10 years, if a person presents with seizures, we have to think of childhood absent seizures. What they have is that they have staring spells, many spells, staring and very, very brief. So the child may be writing and stops and then be just looking and then continues. So many of the onlookers and bystanders may think that the child is daydreaming and it starts continuing. So they may not even think that the person is having seizures. So multiple spells, multiple times it occurs, very, very brief, and then they continue the activity without any confusion, like post-ictal confusion. So multiple seizures, staring, spells, they can have automatisms, lip smacking. They'll be writing and then they'll start continuing. Lip smacking, multiple, brief, and very characteristic is that it is provoked by hyperventilation. So if a person, the child is asked to hyperventilate, they may start having the childhood absent seizures. They may have absent seizures. EEG is very characteristic, one of the favorite exam questions. 3 hertz spike and wave discharges. 3, the answer is 3. Always you have to look out for the 3. The answer is 3. 3 hertz spike and wave occurring in 1 second is highly characteristic of childhood absent seizures, and the drug of choice is ethosuximide. If it is not available, we can give sodium valproate. So important points is that EEG is very characteristic of childhood absent seizures. It's about 3 hertz spike and wave discharges, and the drug of choice is ethosuximide. If it is not available in that particular country, sodium valproate can be given. Right. The next common seizure type what we see is benign Rolandic epilepsy. Again, it occurs in slightly later childhood, 4 to 11 years. Benign Rolandic epilepsy, as the name suggests, it is benign. Nothing to worry of. It is remitted in nature, self-resolving, so nothing much to worry about. It's benign. Rolandic, it occurs in the parietal areas, the frontal areas, parietal areas, and epilepsy. So what we call it is benign epilepsy with centrotemporal spikes. So central regions gets affected, and the spikes we see it in the central and temporal region. Because of the region occurring in the centrotemporal spikes, mainly the facial muscles get affected. Either they can have facial twitching or the facial sensations, impairment of facial sensations. So seizures, and another characteristic of benign Rolandic epilepsy is that these seizures usually occur during sleep. In fact, sometimes these are known as nocturnal seizures. Very, very important. If the parents notice that the person is having seizures during night, always suspect benign Rolandic epilepsy. So these seizures occur soon after they get into sleep. So you see it in sleep. So it is known as a nocturnal epilepsy. And before they awaken, so it is during the sleep they get it. And they have the paresthesias of the mouth and face, sensory disturbances. They have facial twitching with drooling. As I said, it occurs in the centrotemporal regions, so the facial sensations and the facial muscles get affected. They spontaneously remit, nothing to worry of. Benign Rolandic epilepsy, as the name suggests, is benign. We need not worry about, spontaneously remit. But if the parents are concerned and if we think the seizures are not really getting adequately controlled, since it's a focal form of seizures, we give carbamazepine. Because carbamazepine is a drug of choice for focal seizures. The next seizures, what we commonly encounter is in the slightly older age group, adolescent age group. Now we are talking about teenage, that is 13 years to about 19 years. So adolescent age group, if we see seizures, that is the juvenile period, and they throw seizures which are myoclonic in nature, we call it as juvenile, because you see in adolescent age group, myoclonic, they throw myoclonic seizures and it is known as epilepsy. JME, juvenile myoclonic epilepsy. It occurs during adolescence, and the myoclonic seizures or jerks involve the upper extremities, especially in the morning. So one of the characteristic history they give is that a lot of children, when they get up in the morning, they have a tendency to have coffee. So when they are having coffee, they have myoclonic jerks and they are not able to sip coffee well. So the usual history is that the children they're not able to drink coffee in the mornings. So if you get that kind of history, you should always suspect juvenile myoclonic epilepsy, especially if the age group is in the adolescent age group, that is in the teenage, 13 to 19 years of age. So a teenage person and adolescent age person having difficulty in sipping coffee in the mornings, you have to suspect JME. So they have myoclonic jerks coming up in the mornings in the upper extremities. And they are very much sensitive to sleep deprivation. So when they do not get adequate sleep, they have a tendency to throw seizures and develop juvenile myoclonic epilepsy. So we should always ask about the adequacy of sleep, whether they are having good sleep or not, because sleep deprivation is one of the important provoking factors for juvenile myoclonic epilepsy. Like hyperventilation is a provoking factor for childhood absence seizures, sleep deprivation is an important provoking factor for JME, juvenile myoclonic epilepsy. The EEG is again characteristic, like for childhood absence seizures, like we have 3 Hz per second spike and wave per second. Here we have 4 to 6 Hz spike and polyspike waveforms. So the EEG in juvenile myoclonic epilepsy is very characteristic, 4 to 6 Hz spike and polyspike waves. The treatment is lifelong, unlike other epilepsies where we may give for a few years and then stop it. The treatment for juvenile myoclonic epilepsy is lifelong, very important point. Lifelong they have to continue. And usually the drug of choice is sodium valproate, and another alternative is levetiracetam. Because sometimes sodium valproate can cause hepatic encephalopathy or ammonia, especially the hyperammoniac encephalopathy. It can affect liver and cause hyperammonic encephalopathy, sodium valproate. So if they have problems with the liver functions in juvenile myoclonic epilepsy, we can switch over to levetiracetam. Otherwise, we generally give sodium valproate. But if the person has got liver disorders, hepatic involvement, hepatic problems, and they have tendency to develop hyperammonic encephalopathy, especially in children less than 3 years, but JM is okay, it is in the teenage, but still if they have any problems, chance of developing hyperammonic encephalopathy, please switch over to levetiracetam. The next seizure type, what we encounter is Landorf-Kleffner syndrome. It is acquired epileptic aphasia. It is again usually seen in the age group of 3 to 7 years as the Landorf-Kleffner's syndrome. Basically, it is an acquired aphasic disorder with EEG changes. So the child has developed well the child has started speaking, but then after some time the child is not able to speak and there's a regression of language. So if that is the kind of history we are getting, we should always suspect land of cleft syndrome, acquired aphasia. So the child has developed speech well, but then there's a regression of speech disorder, language disorder. So acquired aphasia with EEG changes, we have to think of land of cleft syndrome, and the drugs which we give is anti-epileptic drugs and corticosteroids. Another important seizure disorder is the Rasmussen's encephalitis. It's a progressive encephalopathy. There's a cortical atrophy, so they can have hemiparesis, the seizures on one side, a progressive encephalopathy because of the cerebral atrophy. It's Rasmussen's encephalitis. Because of the cerebral atrophy, they have the hemiparesis. So we have to, it's a refractory treatment. Nothing much can be done, but we still try. The treatment involved is that they have suspected that it could be because of anti-glutamate receptor antibodies in autoimmune pathology. So since it's an autoimmune disorder, NMDA receptor antibodies involvement, so we have to give immunomodulatory drugs, immunosuppressants like steroids or intravenous immunoglobulins, and still if it is not able to control, if there is refractory seizures, sometimes you can go for hemispherectomy because it is a localized disorder, cerebral atrophy. So this is Rasmussen's encephalitis. So the words which we are looking for is a progressive encephalopathy and autoimmune nature, NMDA receptor antibodies involved, anti-glutamate antibodies being involved. Right. Now finally let me talk about status epilepticus, and then I'll wrap up, I'll summarize all the important concepts. So status epilepticus, I'll be talking only about the principles of management. The details can be read from any book. The principles of treatment are that first, what is status epilepticus? There are three important points. One, it is a repeated seizures, repeated generalized tonic-clonic seizures without regaining consciousness. So person keeps on throwing seizures without regaining consciousness. It could be status epilepticus, or any seizure which is going on for more than 5 minutes. It could be status epilepticus, or repeated seizures for 30 minutes or longer, again status epilepticus. So repeated seizures for 30 minutes or longer, or seizures going on continuously for more than 5 minutes, or repeated seizures without regaining consciousness in between seizures. All these three will merit a diagnosis of status epilepticus. So the management principles includes, most important is we are always looking for a correctable disorder. So we have to think of any metabolic impairment, especially hypoglycemia. So we have to check out on the glucose levels. If it is hypoglycemia, we can give dextrose. And then we follow a certain protocol. For example, till about 5 minutes, because most of the seizures are not status epilepticus, they are going to spontaneously stop. So we can wait for about 4 to 5 minutes. If the seizures are not getting controlled and is going beyond 4 to 5 minutes, then we give lorazepam, IV lorazepam. That is a drug of choice. But if the seizures are still going on even after 15 minutes of time, then we give the second line agents, that is IV phenytoin 20 milligrams per kg body weight, or levetiracetam, or phosphonate, or sodium valproate. If the seizures are still continuing, even phenobarbital can be given, especially in children. If the seizures are still going on even beyond 45 minutes, then we go for anesthetics like midazolam or anesthetic drugs. So these are the principles of management of status epilepticus. So the watchword is that we always look for hypoglycemia, the treatable cause. If it is there, we correct it, and beyond 4 to 5 minutes of time, if the seizures are not going to stop, then we have to initiate IV lorazepam followed by other anti-epileptic drugs if the seizures are not under control. Right. I've been talking about so many important concepts. Now let me summarize all the important concepts. First is infantile spasms. As the name implies, it occurs in infants with cluster of seizures. The treatment is adenocorticotropic hormone, ACTH. Axon seizures, it occurs in the age group between 4 to 8 years. The EEG shows a characteristic 3 Hz spike and waveform, and the treatment is ethosuximide. If it is not available, we can go for the other drugs. The benign dolandic epilepsy, as the name suggests, it is benign. It is seen between the 3 to 10 years age group. The seizures occur during sleep. In fact, nocturnal seizures, always we have to think of benign dolandic epilepsy. The face gets involved, the facial sensations, numbness or facial twitching, and they spontaneously remit. Juvenile myoclonic epilepsy occurs in adolescents, usually seen in mornings. So the characteristic history is they are not able to sip the coffee without spilling the coffee. And then the EEG is characteristic. They have 4 to 6 hertz spike and or poly spikes. The treatment is lifelong. We usually give sodium valproate. If there is any hepatic problem, we switch over to levetiracetam. Occurs in adolescents, morning seizures. Then we have the Landorf-Kleffner syndrome as a name. Landorf-Kleffner syndrome. It is an acquired aphasia, that is, they have developed the language well, but after some time there is a regression of language functions with associated EEG changes. The treatment is we give anti-epileptic drugs, sometimes steroids. Lennox-Gastaut syndrome, it is because of the severe brain damage occurring diffusely, severe severe brain damage, and therefore the EEG shows a very slow diffuse pattern, about 1.5 to 2.5 hertz, intractable seizures they have, and they have a severe intellectual disability. In fact, as I said, it's a continuum: infantile spasms, West syndrome, and Lennox-Gastaut syndrome. So Lennox-Gastaut syndrome is the highest form of this epilepsy seen in the children, highest form of impairment, and therefore if you're not able to control at the level of the infantile spasm, they may go on to develop intellectual disability. Then we have Rasmussen's encephalitis. It is because of a cerebral atrophy. It's a progressive encephalopathy. They have seizures. Usually it is focal seizures and anti-glutamate antibodies. So we have to give the immunomodulant drugs. The EEG, by just looking at EEG, we can make a few characteristic seizures. If it is 2 hertz, very slow, diffuse, it is Lennox-Gastaut syndrome. If it is 3 hertz, it is absence seizures, 3 hertz spike and wave. If it is 4 to 6 spike and polyspike waves, it is myoclonus. So by just looking at EEG, we get a lot of information, especially in pediatric epilepsy groups, and these are the important epileptic seizures which we see. And of course, most important is febrile seizures. It is because it is most common, and really nothing much to worry. It occurs during fever and the peak of fever, and most of the time the simple febrile seizures, they do not go on to develop epilepsy. So we can give clobazam, which can be used as an intermittent form of epilepsy therapy. So these are all the overview and important concepts of pediatric epilepsy. So this is pediatric epilepsy in nutshell. I hope you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly post onto my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.